FDC or RIPA and Vogelibos, mode of action, indication and doses, side effects, clinical evidences, and the summary. So this is old 2019 IDF Diabetes Atlas, and we see that there is the global standard 9.3 prevalence of diabetes and almost 463 million diabetics worldwide. If you come to the India, 8.9% prevalence in 2019 and 77 million diabetic population. Now it has been changed recently. So the latest data on June, and it was there that India is home to the second largest number of adults living with diabetes worldwide after China. But now the things have changed. We have surpassed China in population as well as the diabetic population in the world. So India is now the diabetes capital of the world. It's official. It's the June 2023 data. It is recently published in the Lancet Diabetes and Endocrinology Journal. The study conducted by ICMR India Diabetes confirmed that India is home to almost 101 million diabetics. That's alarming and that's scary also. The ICMR studies said that diabetes cases has increased by 44% in 4 years. Huge, humongous. The study also said that 15.3% of population, at least 136 million people is pre-diabetic as compared to around 80 million in 2019. So we have grown too much. So looking for the glycemic pantad, right, we have the PPG, that is post-prandial blood glucose. Then there is HbA1c, fasting plasma glucose, hypoglycemia and glycemic variability, and now we can add the sixth one, that is time in range also. That is also coming up in a big way. So I just have a word with the speakers, the chairperson, that which is more harmful, like it is fasting plasma glucose or post-prandial plasma glucose. So we just talked about fasting PPA1C. So which is most harmful?
All are harmful, but
yes,
we usually go first for fasting and HbA1c first.
People say that fixed fasting first, right? Yeah. And a lot of this emphasis are given on fixed fasting first. It means that fixed fasting first is fasting is more harmful, right? But we don't discuss about this post-prandial hyperglycemia. That is a big way, and I thank the organizers to keep this topic in this beautiful conference. Okay. So what happens in insulin secretions after meals? We have taken the meals, and what happens, right? So there's the first phase insulin secretion. It begins within 2 minutes of food ingestion and continues for at least 10 to 15 minutes. And the second phase, insulin secretion sustained until normal glycemia is restored, and this is the normal pathophysiology, the pharmacokinetics of insulin. So what happens? The loss of first phase insulin release is the earliest change in the development of type 2 diabetes, and this is the contributory factor to the rise in postprandial blood glucose. So STAR study is a very great study which revealed that Indian diabetics consume diet which is rich in carbohydrates. Dr. Vinod Mittal is there, and we have talked a lot of conferences regarding these issues. And it is not in north-south; it is everywhere. North, east, south, west. You can see this is the prevalence of the whole country, and you can see the proportion of carbohydrate is prevalent everywhere, being north, being east, being central. So carbs constitutes about 64.1% of total energy from diet. Similar findings across all zones in India with respect to carbs consumption, and PPG of 62.5% diabetic populations were above target of 180. That we are talking about that the target should be less than 180%. Inadequate glycemic control in diabetic patients might be related to the higher dietary carbs consumptions among the Indians, and that's most important. So what are the key questions that has to be answered? Is PP post-prandial hyperglycemia harmful? As we have talked that sometimes we are going emphasis on fasting plasma glucose. Why it is important to control post-prandial hyperglycemia? What are the current available therapies for management of post-prandial hyperglycemia, and what are the limitations, right? And definitely, what is the solution of it? So the question I asked that is post-prandial hyperglycemia is harmful, right? So epidemiological and intervention studies have shown that post-prandial hyperglycemia is direct and independent risk factor for cardiovascular disease, and this is I think most important point, because what we are worried about, we are worried about the cardiovascular morbidity and mortality. And the patient having the post-prandial hyperglycemia, CVD risk is immense. So post-prandial hyperglycemia is a contributory factor for atherosclerosis, non-enzymatic glycation, and productions of free radicals that would lead to endothelial dysfunctions and ultimately cardiovascular poor outcome. So this correcting the post-prandial hyperglycemia may form part of the strategy for the prevention and management of CVDs in diabetes, right? And we are just looking for. So what is the value of controlling post-prandial glucose? Like a lot of PGs are there. So this is the post-prandial hyperglycemia goals that have been set by different organizations. Like IDF said that International Diabetes Foundation that it should be less than 169%. ACE, that is American College of Endocrinology Conference, says it should be less than 140. ADA says it should be less than 180. European Association of Steroid Diabetes says it should be 135. And RSGI, our own society, says that it should be less than 160. So postprandial blood glucose, we all know, it should be measured at least 1 hour or 2 hours. We usually measure after 2 hours. In pregnancy, I think it is measured every 1 hour because it is quite relevant in that particular situation. Self-monitoring of blood glucose, that is SMBG, should be considered for postprandial blood glucose monitoring, right? So what are the drugs? We all know, which is a diabetes conference, that we all know the drugs which is available for the treatment of both fasting plasma glucose and postprandial plasma glucose. But which are the drugs which are actually helps more in postprandial as fasting? And you can see this. Like this is the glinides, that is netaglinide and ripaglinide. It reduces the glucose absorption. That this alpha glucose inhibitors and this acarbose there, that this restores insulin functions. We all know DP4 inhibitors restores amylin functions, and I think pramlodipine is not still available, but it also helps in the postprandial. Insulin, that insulin secretagogues like sulfonylureas, they actually control both fasting as well as fasting. On the right side, you can see the efficacy of all these drugs. So we are limited drugs which actually controls the postprandial hyperglycemias. So I think this slide is very important. So shifting from the conventional approach to proactive approach is the need of the hour. And you can see that when the patient comes to a clinic, with we say that, okay, you go for diet, then you start with OD immunotherapy, combinations, up titrations, you add base insulins, you add multiple daily insulin injections, and it goes off and on. So we have to be a little proactive, right? So if the patient do not achieve A1C less than 6.5% within 6 months of diagnosis, then intensive treatment is required. And actually we already wait for it, right? So if it's not achieved in 6 months, definitely you have to go for intensive therapy. With intensive therapy, it has been seen that 15% of the patients achieve glycemic target as compared to only 3% with conventional approach. So we have to be a little proactive, and intensive therapy has to be constituted as early as possible, and intensive glycemic control reduces the risk of complications. So what is the unmet need? So maintenance of A1C level and utilizing pharmacotherapies that diminish the loss of early phase secretion that I have already alluded, and subsequent postprandial hyperglycemia is mandatory. So need use of combination drugs from different classes which addresses the unmet need. So this is ripaglinide 0.5 or milligram plus voglibose 0.2/0.3. Combination is already available for some time, and we are not optimizing this treatment in most of the diabetic patients. So what is the insulin secretagogues? We all know that this ripaglinide is a rapid and short-acting insulinotropic anti-diabetic agents from meglitine class, which is not actually sulfonylureas, it's just like sulfonylureas because the receptors are different. And other voglibose, we all know this is alpha glucosidase inhibitor. It is a ADA from AGI class, act as a competitive inhibitors of enzymes needed to digest carbohydrates. So ripaglinide action is glucose dependent. In true sense, not glucose dependent. Actually, it's a very short acting. Elicited insulin release is rapid and brief, taken with meals for postprandial hyperglycemias. Reduce risk of long-lasting hyperglycemia, which we see in sulfonylureas. Improves beta cell functions in patients with type 2 diabetes. Restores early phase insulin secretion. I think that's the most important function of that, which improves postprandial glycemia, and it reduces lipolysis. Efficacy of ripaglinide is similar to SUs and has better potency than netaglinide, which is also the glinide group. They are recommended by various reputed global societies and clinical associations in PP, blood glucose in diabetes, and also in CKD. So CKD, I think, is very important. So ripaglinide exerts direct action on pancreatic beta cells, unlike SUs, and this is mode of action you have seen in different conferences, that how it goes, like glucose is transported into the cell, it metabolized leading to the formation of ATP from ADP. The ripaglinide binds to the receptor different from the SU, not the same receptor, different from the SU receptors. Then there is depolarization and the closure of the ATP-dependent potassium channels. Then there's the opening of the voltage-dependent calcium channels. The calcium influx is there. There is insulin exocytosis, and insulin is being released. So this is how it works. The ripaglinide, unlike SUs, glucose-dependent insulin release helps reducing blood glucose and postprandial glucose levels. So ripaglinide has insulinotropic actions at a glance. If you compare with ripaglinide and sulfonylureas, the distinct binding sites are beta cell membrane, greater insulinotropic effects than with glibenclamide or glimepiride, a more rapid onset actions. Action starts within 1 hour and offset is around 1 to 2 hours only. So you can have the 3 or 4 doses before meals. Greater stimulation of insulin release and reduction in blood glucose levels than glibenclamide or glimepiride. Effects were glucose dependent, with increased insulin levels being a transient effect, whereas the reduced blood glucose persisted for up to 24 hours, and glucose and dose dependent insulinotropic effects are also seen. Other benefits like it improves the beta cell functions in patients with type 2 diabetes as DP4 inhibitors, restores early phase insulin secretion, it improves postprandial glycemia and reduces lipolysis, and rapid onset of action and short-lived hypoglycemic effect. Another class is voglibose. It inhibits absorption of carbs from the intestine. Inhibitory activity on maltose and sucrose is 190 to 70 times higher than acarbose and 100 times higher than xylitol. The clinical significance is as same, but it's the molecule is a class effect. Voglibose reduces oxidative stress generation with the reduction of post-prandial hyperglycemias. Voglibose lowers the daily glycemic excursions and inhibits overwork of the pancreatic beta cells. Increase the release of GLP-1, thus enhancing the insulin secretion from the pancreatic beta cells, and better safety profile compared to other OADs, and those and does not cause hypoglycemia. And this is all action that I've said. After meal injections, the Voglibose, it reduces the delayed distal intestinal absorption of carbs, leads to altered gut microbiome. I think gut microbiota is a different topic altogether, and we are working, the research is on gut microbiota, that how it alters the diabetics, and sometimes if you alter the gut microbiota, it might prevent the diabetes. So a lot of research is going on, so maybe in few years we will see the effect of this gut microbiome. It also reduces post-prandial glucose excursion. It will lead to increased GLP-1 excretion, delayed gastric emptying, and decreased appetite and weight loss, and leads to decreases hyperinsulinemia, which leads to decreased glucagon. Definitely, there is low VLDL synthesis and decreased triglycerides. So it helps in many ways in this compound. So why repaglinide plus Voglibose combination? The question is, so with the use of FDC, law of therapeutic parasomia is possible in diabetes. To overcome high failure rate of long-term therapy and progression of vascular complications, FDC with complementary mode of action should be considered. Insulin secretion enhancer combined with alpha-glucosidase inhibitors will be effective in controlling post-prandial hyperglycemia. Repaglinide is very rapid, short-acting, and 2.5 lower risk of hypoglycemia, and also associated with less nocturnal hypoglycemias. AGI seems to be most effective in inducing post-prandial hyperglycemia. So combination provides better efficacy. Combination restores the insulin secretion pattern at mealtime, which is rational for the development of prandial glucose regulators. AGI is modified rapid insulin release induced by repaglinide. With different mechanism actions, both the molecules supplement each other. No evidence of clinically significant pharmacokinetic interaction between repa and Voglibose, because the action, the sites are different, right? So just one or two slides. So clinical, what are the clinical evidences we have? Is a multicentric randomized open-label comparative parallel assignment clinical trial to evaluate the safety and efficacy of fixed-dose combination of repa plus Vogli versus repa tablets in patients with type 2 diabetes with a background of metformin. And this is the randomized, this is the design of this trial, and it is done in 23 centers. On 200 patients were enrolled above 18 years of age. And this is, the key inclusion criteria was inadequately controlled type 2 diabetes with A1C of more than 7%, and 2 hour PPG more than 200, and metformin on 1000 milligram were included, right? So these are characteristics, group A, group B. So in group A, they were A1C 78% on repa and Voglibose, A1C more than 8%, that is repa plus Voglibose, 0.2 milligram and 0.1 milligram, and the group B, B1 repaglinide only, and in B2 repaglinide 1 milligram. So this is the study design. Just 2 or 3 minutes more. So this is the baseline of this trial, and you can see the results. You can see that at week 24, you can see the change of A1C from 0.5 in the repaglinide arm to 0.9% reduction in A1C. It's significant. And at 24-week changes, you can also see there's decrease in fasting plasma glucose, which we would not expect, and the postprandial exertion was also less, from 32.3 to 62.9 decrement in postprandial glucose. So clinically significant for the repaglinide Voglibose arm, allowing greater optimization of postprandial glucose as compared to A1Cs. So result responder analysis for change from baseline A1C, you can see that 51.3% actually proportional patients responded to this combination as compared to only 37.90% with repaglinide alone. So this combination was found to be synergistic. So high proportions when the repa plus Vogli achieve reduction of more than 1% as compared to repa monotherapy. Right.
Could you please?
Yeah, just two slides more. And this is the result responder analysis for change from baseline A1C, and you can see the proportion is more with the combination therapy. So the result safety, no side effects were recorded in the treatment arm throughout the study period. And these are key messages, that FDC or repa plus Vogli explores the ancillary role of combination of PP blood glucose control that will be relevant in type 2 diabetes management, currently on Indian diet when added to metformin. First study to assess the repa, Vogli's uncontrolled type 2 diabetes and post-prandial hyperglycemia, high response rate of PP control with combination, and complementary action of lifestyle modification strategy for control to PPG. So there were a few studies, I won't go into detail. So just to summarize the last slide. Right. So if you use for repaglinide monotherapy, elderly patient in whom hypoglycemia is concerned, we can use it. Patients with kidney failure, patients taking low dose sulfonylureas who encounter problems with hypoglycemia, and patients with regular meal patterns. So just to summarize, combination therapy of non-sulfonylurea insulin secretagogues like ripaglinide with alpha-glucoside inhibitors will provide better efficacy compared to the monotherapy. Both of them have different mechanism of action, therefore combination will have synergistic action and no evidence of clinically significant pharmacokinetic interaction between Repa and voglibose. I think the combination was weight neutral and had fewer hypoglycemia events than monotherapy. I think this is all I want to say. Thank you very much.
Thank you, Dr. Pankaj, and thanks for a lucid lecture. And like you have reminded us that postprandial glucose is also important, not only fasting and HbA1c. We have so many now new drugs which are cardioprotective, like we have SGLT2, we have GLP-1 analogs. So where will you keep after metformin this combination or a ripaglinide for a postprandial glucose?
Right, it's a very, very important question. I think that 80-23 has actually summarized all the things. So if the patient of diabetes with lifestyle modification and metformin, if they have the ASAVD, you start with the SGLT2 or GLP-1 analogs to begin with, right? The patient is having no ASAVD risk factors. You can try with anyone. I think that in that case, you can start with this non-sulfonylurea ripaglinide in that particular patients with metformin. So the guidelines are very clear, right? ASAVD, you can start straight away. There's no role of sulfonylureas in that case. You start with this GLP-1 receptor agonist and SGLT inhibitors. And if there is it's a clinician choice, whether you start with sulfonylureas or you start with DPF inhibitors. In India, I think the cost issues are always there. The most of the patients, if you see that most of the patients are actually with sulfonylurea metformin combinations.
Yeah, Indian cost is important. Any question from the audience? We can take, yeah.
I think.
So as per the latest guidelines, there are 4 pillars now to manage diabetes. It is not just hyperglycemia. So one is, yes, A1C. The second is weight management. So it will depend. It's not straight away we go for sulfonylurea if patient doesn't have CVD or heart failure. So it will depend on the patient's weight and other parameters. So one is A1C. Second is weight management. Third is cardiovascular risk factor management. And the fourth is cardio-renal protective effects. So in a particular patient, if we want, if patient is lean and thin, can sulfonylureas. If patient is already obese, then obviously we need to manage. So there, SGLT2 or GLP-1 will take over. So this point has to be, and cardiovascular risk management, even, the dyslipidemia. So we have to look for the adverse effects of these agents on these parameters also, on hypertension. Suppose patient is hypertensive. So we should be using agents which even lower blood pressure. So it is not just one that we focus only on baseline A1C, and so there are many factors.
There's a concept of diabetes that Dr. Vinod sir has been actually. So diabetes is actually coming in a big way, right? Obesity and diabetes. Okay. So we have to, add those agents which decreases. I think that now oral semaglutide is also available. So the patient is BMI says more than 30 and patient is diabetic uncontrolled, that definitely you can start with semaglutide even. Over semaglutide the patient can afford this thing. So we have to individualize the patient. We have to individualize what are the characteristics of the patient, what is the BMI of the patient, what is the fasting PP difference. Sometimes you say there's fasting PP difference is more, you can have the drugs and the PP is more, fasting is less, definitely you can choose other drug. So I think it is the patient's initial workup would decide which treatment will be benefited for them.
Thank you. Thank you, Dr. Pankaj, for a very important topic, postprandial hyperglycemia.
Thank you, sir.
I would like to invite our next lecturer,